hand over to Dr. Sudhakar Rao to take the proceedings further and welcome our eminent speaker for the day.
Thank you, Rahul. Good evening, all. Today we have an important session on something which is one of the very important cases as per the exam point of view. One of the we know that we usually get two of the important cyanotic heart disease in exam. One will be Eisenmenger and other will be TOF, apart from others like the Epstein's and all. We have had a long discussion about the other disease like the TOF and physiologies in the recent time. However, Eisenmenger is something which is very less discussed. So we thought today we will have a clinical update on Eisenmenger from none other than Dr. Zulfikar, sir. Sir needs no introduction. Sir has been teaching the DNB and DM students for last many years, and he is an eminent teacher. So without wasting much time, so that we can give more time to the discussion, I'll hand over the session to Dr. Zulfikar, sir. Sir, over to you, sir.
Yeah, thank you. Thank you, Sudhakar. Nice to be with you personally, to be interacting with you. And from Monica, Harnish, Sai, Karan, Harish, and your rest of your friends. I think when you see this particular slide, you will find at the top there is a Arabic word. Actually, it says Ikra. Ikra means read. So that was the first. It was considered to be the first word spoken by the messenger of God to Prophet Muhammad. So that underlies the importance of reading and learning. And at the bottom, you can see, some of you must be familiar with this gentleman, that is Thiruvalluvar, who wrote the Kural. He says that learn what is to be learned and then live the learning. So we are all here, including myself, the apparent teacher, the students, everybody is basically to learn whatever you know from, and then try to apply it in this. So what I thought was an intelligent residence guide to Eisenmenger syndrome, because the exam, the clinical examination, whatever may have happened over the last so many years in advances in medicine, cardiology, evaluation, all those things, the examination, the kind of examination which we are having is basically sort of a stereotype. So you have to be reasonably intelligent, and a little bit of cleverness also is needed to guide us through the examination, because all of us were at some point of time students. Anybody from this our panel, distinguished panel, can you recognize this particular person? Any idea? Anybody?
So maybe Eisenmenger himself.
Yeah, you are naturally. So people will expect that this is a particular topic on Eisenmenger. So actually, this is not Eisenmenger. This is actually Charles Dickens. Just to start, this is Charles Dickens. Anyway, now Eisenmenger, actually, it's a really it's a pre-lethal and a pre-capillary pulmonary hypertension. It has no business to be here. Should not happen ideally. And it is non-operable. But fortunately, it has been coming down in incidence, definitely from the days when I did my DM in the early 90s now to almost 30 years. It is definitely coming down in incidence in adult practice. And there is a lot of scope for pharmacotherapy also, even if you pick up a Eisenmenger a little late in the natural history. Now, this again is not a medical person. But who is this particular person who is very much intimately linked to our protagonist? Our protagonist happens to be Eisenmenger, Victor Eisenmenger. Can anybody think of it's a difficult area because this is not medicine. Now, this gentleman is actually was Archduke of Austria, was called Francis Ferdinand. And he is very important. He was assassinated in the street, and that started the beginning of the World War I. That is why the Archduke of Ferdinand is always remembered by history students, not necessarily medical students. But the point is that the gentleman, protagonist of ours, who is medically involved, was a physician to Archduke of Ferdinand, and he wanted to pursue a career of art and natural science, but took to medicine because that is very important. He felt that his talent was not exactly high. So the doctors, we should always be very humble. Just because we are cardiologists or doctors, I think we may not be as talented as people of art and natural science. So this gentleman is Victor Eisenmenger, and he wrote an article in 1897 in German, and he described the anatomy, physiology, and the diagnostic of what we now know as the Eisenmenger syndrome. He never used that particular word. So if you translate it into a reasonable English, it will read as a congenital defects of the ventricular septum. And this was a VSD with a problem, a cyanosis. Now this, I think, Harnish should know. There are two people here, and can you name the leading lady and the greatest ever thespian of Indian cinema?
Is that Madhubala, sir?
Madhubala, it is Madhubala, and who's that very handsome gentleman?
Rajesh Khanna.
Rajesh Khanna. Rajesh Khanna was very young. He was maybe as a toddler when Madhubala was active.
Sir, Dilip Kumar.
Actually, it's Dilip Kumar. And why is this picture in this discussion? What is the reason for putting this particular?
Madhubala had ASD, if I'm not wrong.
Oh, okay, right. So Madhubala was a great actress who had a ventricular septal defect with an Eisenmenger, and she died very young, at the age of 36. So that is the reason why Madhubala is linked to our particular syndrome. Another question to you, again to the panelists. Paul Wood, who described Eisenmenger syndrome, was born in
India, sir.
India, sir.
Australia, India. Very good. Very good. Absolutely correct. Because he was born in Kunur. He studied in Australia for all the medical degree, and he celebrated as the Gale Force of British cardiology. And you see he's 1907 to 1962. It's only 55 years. See, many people, we know, great people live for only 35 to 50, 55 years, and they do a lot, much bigger than what many other people do. So, and he wrote what we call as an epic document, which is now almost 6 decades young. And just like Cleopatra, age cannot wither this particular article, 2-part article, which I think all the exam going students and all your teachers, your examiners also would have read this particular thing, not only for the historical importance, but the relevance. That is the point. It's even now, the 1958 article is very relevant to the practice of cardiology in Eisenmenger syndrome. So the timeline is that in 19th century, it was described. In the 20th century, we got an understanding thanks to Paul Wood. And in the 21st century, I think a lot of drugs have come in to ameliorate this problem and improve the natural survival. So in 87, Victor Eisenmenger, he did not mentioned as Eisenmenger, it was coined by Paul Wood again. Then the first time people realized that this particular disease described by Victor Eisenmenger was actually having severe pulmonary hypertension with a reversal was actually Richard Byng of the Stossing-Byng duo. And then in 58, Paul Wood coined the term Eisenmenger syndrome. Both the term Eisenmenger complex and Eisenmenger syndrome is coined by Paul Wood. Now the basics, we all know these basics. Just to begin, whenever you diagnose PAH, it means pulmonary artery mean pressure should be more than 25 millimeter with a normal pulmonary artery wedge pressure. And to calculate the PVR, you should have this particular formula, which we are very familiar with. And we know the normal PVR is 1 to 3 Wood units. So that is the reason, again, after Wood. And the normal SVR is around 18 to 24 Wood units, which we know. And then if you look at the Dana point classification, which you are very familiar with, because PAH is a very important topic, it's increasingly becoming important. And PAH with a congenital heart disease, we have 4 subsets. One, of course, is our topic of today, that is EISENMENGER syndrome. The second is a left to right shunt with PAH. That is what we call as a large shunts with hyperkinetic PAH. Then a very interesting situation, very delicate and maybe unfortunate situation where a small baby or an infant will have severe pulmonary hypertension with a coincidental congenital heart disease, a small ASD. Actually, today, this particular day, I was following about another baby, a 6-month-old baby who has a 8 millimeter or 6 millimeter ostium secondum ASD with the subsystemic PA pressure. So where, it is safer not to tamper with an ASD. And of course, the last one is a post-operative pulmonary hypertension. And we know the definition, I think, this original definition of Paul Wood remains, that is pulmonary hypertension due to a high PVR with reversal or bidirectional shunt at aortopulmonary, ventricular or atrial level, with generally PVR being above 12 units and PVR-SVR ratio being more than 1. This, I think, again, as Dr. Sudhakar was, it is something like a priming towards your examination. So some of the examiners might ask you the definition of EISENMENGER syndrome, just like they ask you the definition of pulse and all. I think that is a practical point. Whereas then they will ask you, what is the difference between an EISENMENGER complex and an EISENMENGER syndrome? EISENMENGER syndrome, as you know, is a VSD with EISENMENGER, whereas EISENMENGER syndrome means it includes all defects which can lead to a severe irreversible pulmonary hypertension. And this is a general classification of EISENMENGER syndrome. You divide them during your MBBS days, we are only bothered about the number 1, that is simple, which could be divided into pre-tricuspid shunt, that is atrial septal defect, post-tricuspid, of course, VSD, ductus, epivendo, and atrioventricular septal defect. But as we became postgraduate, we knew that there are other complex anomalies which also have an EISENMENGER reaction, which can be at the ventricular level, like a single ventricle and a double outer right ventricle with PAH unless we intervene. At the great vessel level, you have the truncus, and also can have a DTGA, even without a VSD, leading to EISENMENGERization as early as probably 1 year or 1.5 years. And we have, of course, the post-surgical palliation problem, the old ones, the Waterston, POTS, and the central shunts, which can produce severe pulmonary hypertension. Now, we will introduce ourselves to one particular scene where you had the real world scene. A 19-year-old girl had a history of dyspnea for the last 6 months only, and history of having a hole in the heart in infancy with some symptoms. She was advised, or the parents were advised, that a curative procedure can be done, but the baby somehow became asymptomatic and was lost to follow-up. Now she is in functional class 2, 1 near syncope she has, a history, no obvious cyanosis, but upper limb saturation is 95% and the lower limb saturation is 82%. So people have taken very vigorously EBGs from the right radial, left radial, and femoral, and you will find that the PO2 differs, is normal in the right radial, low and lower in the femoral. And the saturation was 95, 86%, and then 82%. So this is a very classical PDA EISENMENGER. We know that this is a PDA EISENMENGER. The aortic pressure was 100/65 and PA pressure was 96/60 with a definite what you call as a differential saturation and differential cyanosis. So the basic theme is that EISENMENGER syndrome presents by 2nd and 3rd decade. That's very important. But actually, it is established by 2 to 3 years. There's a star there. I will come to that. So this is a very important question asked in the examination. They will ask you, what is the average presentation of EISENMENGER? That is different. Maybe early 20s or so, whatever, or late teens and all. But when does it get established? That is usually by 2 to 3 years. That is a very important thing, except for an atrial septal defect, where we will know later that the establishing of EISENMENGER reaction usually happens on the around 20th year or so. And there are some cardiologists who believe that this is not a typical Eisenmenger reaction to an ASD. ASD may be having a potential for developing some sort of an idiopathic pulmonary hypertension. It is something different. The ASD with so-called Eisenmenger is little different from the rest of the left right with the Eisenmenger. And you also know that the early Eisenmenger can occur in atrioventricular septal defect. See, AVSD, especially in a Down syndrome, by the time of 1 year, I think 30-40% of them develop Eisenmengerization. Truncus, of course, DTGA, single ventricle, all can have a very early Eisenmengerization, less than 1 year. Now, another question to your panelists. Histopathological classification of PVOD changes in the lung in 1958 was described by
Heath-Edwards, sir.
Heath-Edwards, sir.
Edwards. Are you aware of this lady, Rabinovich? Yeah, Rabinovich is in Moss Adams. If you read PH chapter, you will find there is another classification by Rabinovich. She's a she actually, and she is one of the greatest cardiac pathologists of the current scenario. Yes, so she has a classification. Lake Louise, all you know, it is basically related to myocardium and myocarditis. Anyway, so this is the Heath-Edwards classification. I will not go into the details. Basic thing is that the first 3 stages are essentially reversible. 5 and 6 are definitely irreversible, and stage 4 also most likely irreversible changes happen. And why does a left to right shunt develop an Eisenmenger? There, I'm spending only one slide on this because we are going primarily towards the clinical evaluation. Now, you can have an increased pulmonary blood flow and exposure to pulmonary vascular bed to a systemic pressure, like in a PDA, high PA pressures, vascular remodeling, all this go into PVOD. And there may be a lot of histological changes which can occur, which would be definitely irreversible. Now, this picture, this is a great, this painting is a Italian painting by an Italian painter called Lanfranco. This, as you can see here, you can see the mother and the baby, the gentleman who is likely to be a physician, and he is, of course, palpating his radial and the pulse, and there is an ox. Can you see that ox in a small picture somewhere there? And I think on the table, there is a book by Hippocrates also. So this was a very famous painting. It's called A Dropsical Child. And the child, if you look very carefully, when you, after our discussion, when you Google this picture, you see the big picture, you will find the child is little blue also. So no, just to tell you that this may be one of the earliest depiction of congenital heart disease, possibly even congenital cyanotic heart disease. So now the today's question is, when you have a suspected Eisenmenger syndrome, what would be the examination-oriented approach? Now this slide, I was, because my erstwhile teacher, my mentor, Dr. Taragan, who was the HOD of cardiology in Chitra, whenever I used to say exam-oriented approach, he used to be very angry with this kind of statement, because he said there is, in cardiology, learning is not through examination-oriented approach, but practical realities force us to go through this particular situation. This was another real life situation. An 18-year-old girl, again similar, diagnosed to have a hole in the heart in infancy, initially on medication, became better. And actually this particular lady, the parents were actually sort of as very strong believers and all, and they went for this prayers and all, and she became better. And later now has come with the desaturation, single second sound, which is very loud and hardly any murmur in the pulmonary, grade 1 murmur. The diagnosis, of course, was a clinical diagnosis was an Eisenmenger, most likely a ventricular septal defect. And this particular data, I think you should be aware, very largest, one of the largest data of adult congenital heart disease and Eisenmenger syndrome from Netherlands. It's a large number, and they found that around 4% had a significant pulmonary hypertension, and 1%, which is approximately 60 of them, had a proven Eisenmenger syndrome even in the current era. And what was happening in the 50s when Paul Wood was discussing Eisenmenger was that of all the VSDs, around 10% of the VSDs became Eisenmenger. Nowadays, because of our intervention, hardly 1% of VSD turn into Eisenmenger, and our aim is to make it near zero. Another question is that among the standard left directions, that is ASD, VSD, and ductus, which presents with Eisenmenger at the earliest and why? Yeah.
Sir, PDA.
Yeah.
Presents
PDA.
earliest.
It's PDA, correct. Why? What makes it different from VSD? What could be the reason?
So because in PDA, the systemic pressures are transmitted to the pulmonary arteries both in systole as well as diastole.
Exactly. So it is from the beginning, right? From the beginning, and both systolic and diastolic pressures are directly transmitted to pulmonary arteries. So naturally, that is the most likely reason for this particular phenomenon. So we should know, this is a very important slide, I suppose, because the VSD, we should know, establishes Eisenmengerization, if it is so, by around 2 years, PDA 2 years, whereas ASD is by 20 years. And this around your right-hand side is the Paul Wood series, where the average age of development of Eisenmengerization symptom presentation is different from Eisenmengerization. It's 22 years, 19 years for ductus, and 35 years, middle fourth decade in atrial septal defect, which probably people will ask this particular questions on establishing and presentation. And we know the symptoms of severe pulmonary hypertension, dyspnea, fatigue, syncope, chest pain, hemoptysis, stroke, and of course, sudden cardiac death. And we all know that fatigue is due to basically a low fixed cardiac output. Syncope can be due to an arrhythmia or a low cardiac output. Chest pain is, of course, due to the RV ischemia. And stroke can be either a paradoxical embolism of a right-left shunt, maybe a thrombosis because of hyperviscosity, or even an intracranial hemorrhage. And sudden cardiac death can be due to an arrhythmia. Now, on examination, we know that cyanosis can be variable because some of the Eisenmenger, they may not have clinical cyanosis, but the saturation may be in the 90s. And the clubbing also is present, but usually mild to moderate unless it's a very late the presentation to the clinician. BP and pulse will be normal. And we know the JVP can show usually a wave. In a relatively well-preserved Eisenmenger, you will have a prominent A wave. Whereas if you go into a RV dysfunction, you will have a prominent V wave. There are other reasons also. We'll come to that later. And one of the most striking thing about Eisenmenger, as you know, is that there is no or minimal cardiomegaly. Of course, with that red star, we will discuss that. And you will expect an RV apex, you will expect a left parasternal heave and a palpable P2. Generally, LPH and palpable P2 are present. They may not be very impressive, but they are there. That is very important. And thrill is very unusual. That is another important point. And S1 is normal. S2 basically will have a loud P2. Again, I put a star. We will come to that again. RVS4 as expected, and RVS3, of course, when you have a RV dysfunction. These are all known to you, but I was just going through this. And you will get a vascular ejection click at the pulmonary area. And murmurs are not prominent. Even if I have written 4 murmurs, you should remember that in Eisenmenger, majority of them will have a very insignificant murmur. One insignificant murmur will be 1 to 2 by 6 mid-systolic murmur at the pulmonary area. Another would be a TR murmur in the lower sternal border, a PR murmur of early diastolic murmur, and sometimes if you have a severe RV dysfunction with oleum overload and all, you can have theoretically a mid-diastolic murmur also, which is very, very rare. But the basic point is that murmurs are not very, very prominent. And of course, you should also know that Graham-Steele murmur, I think due to hypertensive PR, indicates a severe pulmonary hypertension. And some people say that this is slightly more common in PD Eisenmenger, but that's a very, very, very soft finding. So in the examination, suppose somebody asks you, what is the importance of Graham-Steele murmur? The two answers are: one, it indicates definitely severe pH pressure, maybe at least 70 to 75 millimeter of mercury, and could be little more common in PDA Eisenmenger, but it's all relative. Now this particular slide, I am very fond of this slide because I made it for myself for looking for evidence of pulmonary hypertension, any patient, not only Eisenmenger, because PAH, you can get a short case, idiopathic PAH will come as a short case, a RCM with PAH will come as a short case, a postoperative PAH can come as a case, Eisenmenger can come. So what I thought was, I divided for your convenience into 3 groups. The first group is a general group, that is elevated JVP, parasternal heave and epigastric pulsation, RV apex, and palpable P2. 4 basically visible and palpable thing. Then 4 audible sounds, which are RVS4, RVS3 with their implications, an ejection click, and invariably a loud P2, which can of course be single. Then 4 murmurs, usually 3 murmurs, that is mid-systolic murmur, pan-systolic murmur, and an early diastolic murmur. So this is a 4×3 formula. Would be very, basically in the examination hall, you can just mentally tick in which are the findings which I am getting in this particular patient, so that I will support the diagnosis, my diagnosis of a severe PAH with these particular findings. Now, another question to you is, this Eisenmenger syndrome is called a complex Eisenmenger. Which one? AVSD?
AV canal defect and
AV canal defect. Who said that? Harish?
Sai.
Sai Karan. Anybody else have a different opinion? See, again, Sai, I showed you one slide where we classified Eisenmenger into simple and complex. Simple contained all the standard things, that is atrial septal defect, VSD, PDA, AP window, and AVSD. Whereas the complex Eisenmenger is that of a single ventricle DORV truncus, that's odd admixture lesions, a transposition. So here the answer, the correct answer is truncus arteriosus. AVSD, AP window, VSD are basically considered a simple Eisenmenger, not a complex Eisenmenger. Now this question, squatting is present in the history of which Eisenmenger? This is again sometimes asked.
VSD, sir.
VSD Eisenmenger.
VSD Eisenmenger is the one which has got a, it seems to be around 5% of them will have, 5 to 10% will have a squatting history. So that is also very important, because this is very important when sometimes you have, as you will come later, you will find that once in a while a very severe fallow can also clinically look like an Eisenmenger. We will see that. So the point here is, when a candidate or a resident comes into an adult survivor with a congenital cyanotic heart disease, with a previous history of a congenital heart disease or not, with a palpable and a very loud S2 and minimalistic outflow murmur, we think of course of a pulmonary hypertension. So I would say that these are actually different kind of conditions, but somehow in the exam hall, these are the possible things which you have to think of. One is, of course, idiopathic pulmonary hypertension, because an adult with evidence of severe PAH1 differential diagnosis has to be idiopathic PAH. Once in a while, we will find left heart disease with severe PAH. Classical example is a right restrictive cardiomyopathy that could come as a severe PAH. Then a very interesting thing, 3, 4, 5, they are so far away from pulmonary hypertension because they do not have pulmonary hypertension, but still clinically they may mimic Eisenmenger syndrome. We will come to that later. But physiologically, it is like, it is totally different situation. So what I would say, I would now do is first try to give you a clinical differential diagnosis between the 3 major phases of Eisenmenger syndrome, which I think is very important in the exam also. That is an ASD Eisenmenger, a VSD Eisenmenger, and a patent ductus arteriosus with an Eisenmenger, where you can see the differential clubbing also with the cyanosis. Dr. Monica, do you have any questions in the chat box at present? Because we have covered 30 minutes. So if there are questions, chat box, we can go through them. Or shall we continue?
We'll continue, sir. At present, nothing, sir.
Nothing.
Yes.
So now I think this is one important body which I think is very important in the examination. But in reality, as you will know later know, in reality, there are only very few points which we'll try to distinguish.
Can I have one question here? Like just
please. Yeah.
Like history-wise, based on history, though history is not given much importance, based on history, we can tell that some symptoms goes for this Eisenmenger's, like a deep cyanosis goes for something, or fatigue or less effort tolerance goes for, like, is it possible?
Yeah, to some extent, yes. That is, for example, see, whenever, whatever, even though we feel that the Eisenmengerization starts by around 2 years or so, suppose there is a definite history by either by the bystander that this particular person had a blue color by 18 months or 1 year or so, it is probably less likely to be an Eisenmenger. So that way it is important. The history of cyanosis is a very important thing. Whereas fatigue and all, many of the differential diagnoses like idiopathic PAH, Eisenmenger, these are all having significant fatigue. So, I mean, and secondly, a significant proportion of adults who will present with Eisenmenger usually will have minimal cyanosis. So if you have a very deep cyanosis, which has been there only recently, then I think probably it is less likely to be an Eisenmenger syndrome. So these are all difficult areas, because what happens in the examination is that there may be some fixed people. There may be some cases of Eisenmenger or an Epstein. They are reasonably comfortable. They will be asked by the department to come for the examination. So some of them may be slowly going into severe polycythemia. So when a candidate sees that person who is 34-year-old and who has been having an Eisenmenger, he will have severe cyanosis and severe clubbing. Then we will think, oh, this probably is not an Eisenmenger. It is something else like a pulmonary atresia with the VSD. So that is also possible in real life.
Thank you, sir.
Excuse me, sir.
Yeah.
Just one query, because we discussed this. In complex Eisenmengers, patients will be cyanotic, no? Then from cyanosis, we cannot differentiate, or we can.
It is difficult actually, but the point is that in reality, what usually you get during your DNB or a DM examination is one of the 3 usual standard variety of Eisenmengerization. That is the usual thing. But I still remember one person who had who was he's on 20s in Chitra when I was a student. He had a severe pulmonary hypertension with a mild to moderate cyanosis. It was a persistent truncus arteriosus. So that can happen, but that kind of adult survival. If you look at the survival of what I call as a complex Eisenmenger, for example, truncus arteriosus with PAH, that is the one which will develop Eisenmenger. The 1-year survival is only 15%. Single ventricle with PAH, 1-year survival is only 25%. 1 year, you must remember that. That is very important. So TAPVC with TAPVC, regular ordinary TAPVC, 1-year survival is 15%. So which means that those congenital heart diseases who are likely to develop Eisenmengerization and live up to 20s and come to you for the examination is very, very rare, because most of them would have died. You get my point. So that is a logical point. Now, people have said that this is again an important question people will ask you. That is, if you consider only large defects, what is the conversion rate? So if it is a large lesion, if you don't do anything, if you have an aortopulmonary communication, it may be as high as 50%. Interventricular communication, it may be as high as 50%. And interatrial may be only 10%. That is why we always say that ASD Eisenmenger is not actually an ASD Eisenmenger, ASD with possibly coexisting pulmonary hypertension. So now I am trying to give you the differences between three types of Eisenmengers: ASD, VSD, and PDA. You should remember that most of my data on the next few slides are primarily from Paul Wood's articles, and most of them are very soft differences. Some of them are very strong differences, some of them are very soft differences. You must realize the limitation of classifying Eisenmenger into most likely this and most likely this. We must be honest enough to admit that at the end of the day, we would require an echo or a contrast echo or even a catheterization to decide which is which. The first point I have already told you, transition to Eisenmenger is very rare in ASD, and which means that if you have a person in 20s coming with severe PH and suspected Eisenmenger, it is most likely to be a VSD or a ductus. The age of presentation, which we have covered, ASD, it's actually wrong. Sorry to this thing. That is, age of presentation is actually 35 years for the ASD. VSD is 22 years and PDA it is 35 years. Gender ratio, I think that is to some extent important. That is, we know that the ASD and the PDA have a slightly female, there is a female preponderance. Exercise intolerance, generally, people are taught that exercise intolerance is maximum in ASD Eisenmenger, but according to Wood, there is not much of a difference. And according to him, he feels that the PDA Eisenmenger has a better exercise tolerance given the PA pressure. But some of other studies, even a study done in Sri Chitra by my 1 year senior, Saha, I will come to that again, they showed there is hardly any difference in exercise tolerance. Then angina is common to all, syncope is common to all. Hemoptysis is again more or less common. So the only point is that heart failure, when they present to you, when you see an Eisenmenger, when they have a real heart failure, it is more likely to be an atrial septal defect. That is one soft point. And of course, squatting, we have already discussed. Squatting with an Eisenmenger, it is exclusively a ventricular septal defect. Cyanosis, very, very important point, because, you know, ASD and VSD will have uniform cyanosis, whereas PDA will have a differential cyanosis and sometimes a differential clubbing also. But a very tricky thing. But cyanosis, I think, is very clear. And hopefully, I think DM candidates now are getting a pulse oximeter also in the examination. Then things will be a little easier for you. Pulse volume, more or less okay. Blood pressure is more or less okay. And again, next very important point is the JVP elevation. Everywhere JVP may be prominent, but more elevation would be more in favor of a ASD Eisenmenger. Now there's another question, that is, if you have a PDA, can you have PDA Eisenmenger with a uniform cyanosis? So the answer is usually it may be because of a patent foramen ovale or a small ASD which was there incidentally, and because of the severe PH, there is a right to left shunt or an additional VSD. This could be the usual answers to this particular question on this. Now another question will come, JVP in Eisenmenger syndrome. Suppose you have a very prominent V wave than an A wave, one of course due to TR. Another reason is that when you have an AVSD Eisenmenger, complete AV canal defect with the Eisenmenger, what will happen is that there will be left AV valve regurgitation across the AV canal. So you will have a very prominent V wave. Need not be necessarily due to a tricuspid regurgitation. That is another question they can ask. Then you have clinically very important difference. ASD will have definitely cardiomegaly. We'll come to that again. Precordium will be definitely, there will be some LPS, but probably more active precordium would be seen in ASD. S2 is a very, very crucial area, not only in real life into differentiate, but also in the examination. We all know that ASD majority will have a wide split second sound, VSD will have a single second sound, and PDA can have either a closed split or a single second sound. I think we will explore these once again, because they are very important in the exam situation. And this is actually the data-based on the second sound. That is ASD 80 to 85% will have a wide split, 15% will have a close split or a single. So you must remember that some of the ASD Eisenmenger still can have a single second sound, whereas the majority of VSD Eisenmenger will have single second sound. Whereas PDA, half of them will be closely split and half of them will be single. You know the difficulties. We all know that both the teachers as well as the students know difficulty in assessing second sound, JVP, etc. in a clinical situation. So nobody is infallible. People can make mistakes, but generally we anticipate a wide fixed split, wide split in ASD, a single second sound in VSD, and a close split in patent ductus arteriosus, or even a single second sound. Systolic murmurs, again, all of them will have a short mid-systolic murmur. All of them will have an EDM. There were one or two, I think one article, I think one study, a small study showed there was an increase of EDM, Graham steel, more in a PDA Eisenmenger, but practically more or less the same. And then this question, differential cyanosis is found in PDA Eisenmenger. The answer, what is the answer? All PDA Eisenmenger, 50 to 75, 90%, less than 25. What do you say?
50 to 75, sir.
Because many of the PDA Eisenmenger may not be even cyanotic. You know, saturation may be in the 90s. It may be still an Eisenmenger, one thing. And all of them need not have a differential cyanosis. Wide fixed split, that we have already answered. Wide and fixed split of S2 in ASD Eisenmenger is found in around 80%. The standard 80%. Answer to the standard cliched question in the examination is 80%, 80 to 85%. I think somehow many of the studies have shown almost the same value. So it has to be believed. Now look at the ECG. Honestly, again, I must tell you that it is very difficult sometimes to differentiate with an ECG. But we will try. For example, right atrial enlargement is common to all. Right axis deviation is common to all, except of course the star. That is, if you have an atrioventricular septal defect, some of the single ventricle who have gone into Eisenmengerization, they can have a left axis deviation. We all expect this to have right ventricular hypertrophy. But the fourth point, if it is there, if there is a RVH, with the QR in V1, because in the presence of pulmonary hypertension, there are many other conditions. You know, you should know a list of conditions where you have a QR in V1. That is totally different area. But in the presence of severe pulmonary hypertension, QR means that there is a suprasystemic PA pressure, which cannot theoretically, scientifically occur in VSD or PDA. So if you have a QR in V1, in a case of an Eisenmenger, it is almost virtually certain that you are dealing with an atrial septal defect with an Eisenmenger. And of course, supraventricular arrhythmias are probably more common in ASD. X-ray cardiomegaly, definitely a point for ASD. Then one point which Paul would say is that MPA may be same, large, but right descending pulmonary artery is very prominent in ASD Eisenmenger. And of course, another standard spotter for Roski for a DNB or otherwise also is a ductal calcification with a dilated pulmonary artery. That will tell you that this is of course a PDA Eisenmenger. And the last point also in the examination, generally people are fond of asking, what is the aortic knuckle in this kind of Eisenmenger? We know PDA, because there has been a large flow across the aorta, so aorta will be a little larger. VSD, the aorta will be so-called normal and the other is small. And these are all minor differences. It is very difficult to say that this is so. But you should know these kind of situations. Now, cardiomegaly, that's a very interesting, very important, because, you know, majority of ASD Eisenmenger will have cardiomegaly, which means there is a small percentage which will have no cardiomegaly. Similarly, you should also realize that mild cardiomegaly can exist in VSD Eisenmenger and PDA Eisenmenger. You cannot be dogmatic. Dogmatism is basically an undergraduate philosophy. We must be always open to this kind of difference. So this is also you should know, because even if you get an apical impulse in the fifth left ventricular space in the midclavicular line, you must naturally commit that there is mild cardiomegaly, and then they can ask you why. So you should say that a small percentage of Eisenmenger can have a mild cardiomegaly, not a marked cardiomegaly. So that should be your answer. And another question which is asked, which I think it's very difficult to answer honestly, why cardiomegaly in ASD? The answer given in literature is that there is a pre-existing right atrial enlargement and right ventricular enlargement because the volume overload, as the volume overload has been there for 20 years. That is the point, 25 years. Whereas PDA Eisenmenger, VSD Eisenmenger, the Eisenmengerization happens by second year, third year. So they are not subjected to this kind of volume overload. So that is the most likely reason, because RV, so see, RV has been facing this volume overload for the last 3 decades. Then it develops this. So naturally cardiomegaly is expected. So coming back or not exactly coming back, the key points in the differentials are the gender ratio, the age of presentation, history of squatting, the kind of cyanosis, the prominent JVP, cardiac enlargement, S2 behavior, very important. Then you have QR in V1, ascending aorta, ductal calcium, and these are the things. For example, age of the presentation, ASD, late, gender ratio, ASD, squatting, VSD, differential cyanosis, very easy, PDA, prominent JV, maybe ASD, cardiomegaly, definitely ASD. Second sounds of split, well split ASD. So these are some of the points. And these are the, again, same thing, ductal calcium. I am only highlighting all these points. Now, you know, the usual chest X-ray in an Eisenmenger should show a no cardiomegaly, RV contour, and a prominent this thing with the peripheral pruning, and we should have a pulmonary oligemia. So this is on X-ray, courtesy Dr. Anita Saxena. I think there is a wonderful PowerPoint presentation by Dr. Anita Saxena, which is in the net. You can definitely go through this. It is very useful, not only in real life, but also in the examination. So this is a typical X-ray showing a minimal or no cardiomegaly, RV contour, right atrial enlargement, huge MPA, LPA, and RPA also, RDPA, because you cannot see RPA in a chest X-ray view, right descending pulmonary artery. This was one of our case, unfortunately. He was only some 12 years old who developed an Eisenmengerization. And there is a little bit of cardiomegaly, but you know, it is very evident that this patient is inoperable. And this is a stock X-ray. You know, this is not my X-ray, it's a stock X-ray, which just conveys to you that there is significant cardiomegaly and a huge RDPA. You can see that RDPA is very huge. That is more in favor of ASD Eisenmenger. And you can see the ductal calcium, minimal cardiomegaly, huge RPA, MPA and all, and there is a ductal calcium, which is again a spotter in the examination, ductal calcium. Very, very important. Usually it is shown to us during entry also and exit also of the DM course. Electrocardiography, we know that it is a standard routine thing, normal sinus rhythm, right atrial enlargement, severe RVH, and sometimes QR in an atrial septal defect. This is a standard X-ray. Very familiar with this kind of ECG, right axis, and RR pattern in V1 indicating severe right ventricular hypertrophy. So this was the lady which I was telling you about, one lady who had come with a VSD with the Eisenmengerization. So very interestingly, you will find that there is a small Q-like thing in V1, because we don't expect a suprasystemic pressure in a VSD Eisenmenger. So there was a small Q, so which means that anything is possible, but generally if you have a Q wave, as you will find here in V1, with the right axis deviation and strain, etc., this is, you should think of a ASD with the Eisenmengerization. And this is a 22-year-old girl, has recently become symptomatic, dyspnea and fatigue, has occasional palpitation, has an elevated JVP, saturation is 94%, tantalizingly 94%. With cardiomegaly, with tapping apex, split wide second sound is very loud. So basically thought of an ASD with severe PAH. See, looking at the X-ray, we are surprised because the kind of cardiomegaly what we expected by clinical examination is not there, and there is things look bad for this particular X-ray at least. And ECG shows a RVH, RSR with basically an RVH situation, and echo showed a subsystemic PA pressures with a large atrial septal defect. And this was the, so the question was whether to do a cath or a transesophageal. It is done, cath was done to intervene or not to intervene. And the basal study showed a QP by QS of 1.8:1. This is a real case from Amrita Institute, was borrowed from Dr. Krishna Kumar. PVRI is 5, SVRI is 20, ratio is 0.4 on oxygen. It went up dramatically to 3.5:1. PVRI dropped to 4 and ratio dropped to 0.25. So things were which brighter, and they basically did a device closure successfully, and post-procedure he did very well. That is a positive history of it, but it's a very difficult decision to make because it is almost going into that situation. This was another case, a question to you based on this. Anybody can, 5 of you can choose either of the options. So we will see where the majority wins or not. This was a 15-year-old child with severe pulmonary hypertension with Eisenmenger VSD. QP by QS basal was 1.4:1. PVR was 7 units. PVR SVR ratio is 0.5. Is it operable? Is it inoperable? Or you give sildenafil and then try to operate? What do you feel? What does Monica say? I will write it down. Choose. Harnish, can you choose which one? A, B, C?
I would say it's inoperable, so B.
B, you will put it B. Sai?
I will choose C, sir.
That is, we try to, okay.
I would also say C, sir.
C, 2 people are for C. Then Karan and Harish?
I will say inoperable.
Go for cath. It's 7 Woods units.
No.
But
Tell me.
Considering VSD, I would like to have a drug trial and then reassess.
Drug trial means you give oxygen and do a repeat this thing, or you are giving a sildenafil and waiting for some time. Is it a pure, for example, you can do an oxygen study here. Oh, this is a basal on air. So are we planning that, or are you planning that, or you're telling no, it's not operable?
No, I would like to give oxygen and see.
And then
I would like to do CAT study in detail and see what is the response.
Seems I would also like to do an oxygen cath study first.
And then only I will decide on operability.
So there are, see, basically among 4 or 5 of you, there are definitely difference of opinion. That itself is an important point to remember. And secondly, very importantly, that numbers only, we should not depend only on numbers. There are many other factors also, including the age of the person, the kind of defect. We will come to that. The clinical finding itself, etc., etc. So, but these values are not very happy values. You cannot say that it is operable, because when we come to the current criteria, they do not fulfill the criteria. So we may be justified in doing a oxygen study and decide whether it is operable or not. The main point nowadays, for the last few, maybe 10 years or so, there has been a increase or a elevation of threshold for operating on left to right shunt with severe pulmonary hypertension. People are not very happy to offer them a surgery because of 2 things. One, they may do badly, and Eisenmenger situation, they may do reasonably well in terms of longevity because of the new drugs. But there is the third option, which we will discuss a little later. But that, so I'd probably agree with you. I would agree with you that we should do an oxygen study, but knowing fully well that our threshold for operating is not, it should be lowered. That is the important difference between 20 years before and now, what has happened over the years. So naturally, when you have a PAH in an adult congenital heart disease suspecting an Eisenmenger, the question is to, one is explore operability, second is medical management. And to do or not to do depends on the age, the cardiac size in chest X-ray, very important actually, pulmonary blood flow in chest X-ray, split second, very important. I still remember during my DM days, when you have a 4-year-old child with severe pulmonary hypertension and S2 is split, even in spite of severe PAH with a normal cardiac size, S2 is split. Our teachers used to say that the child could be operable. So that is very important. MDM and the apex, QR. So you should take into account. This is the kind of answers you should come out with in the examination, because rather than thinking only about the values, we should also explore these kind of things, age, cardiac size, everything. So it should be a holistic thing to assess the operability. And of course, this is the kind of thing which I said again and again. And we all know this. This is the 2013 guidelines on P operability. So this is based on baseline value on air. QP by QS should be more than 1.5:1. PVR should be less than 6 units. So you have brought down this. Previously we used to say 8 Wood units. Even Kirkland textbook of cardiac surgery, they say 8 Wood units, but now we have come down to 6 Wood units. PVR SVR ratio used to be 0.5. When I studied, my answer was, the student's answer was 0.5. Now it has become 0.3. So basically telling you that the threshold has become little higher. That is very, very important aspect in operability. So the general feeling is that if it is less than 4 units, it's correctable. If it is above 8 units, definitely not correctable. And between 4 and 8, I think you could individualize. You could look at the other findings. You could try an oxygen study. So never be dogmatic in this thing. And either way, you can sometimes be wrong, but you have to accept that. And what else is then we of course need an echocardiography, contrast echo, especially for ductus, because ductus Eisenmenger in an adult, sometimes it's very difficult to diagnose. Sometimes you need a catheterization, oxygen study. So the only point I want to stress again and again is that threshold for operating is higher now in the presence of severe pulmonary hypertension. Now, complications we all know: hemoptysis, hyperviscosity, CVA. We already covered that. Some of them are less common: cholelithiasis, hyperuricemia, obstructive pulmonary osteoarthropathy, right heart failure, sudden cardiac death, and all. And these are all things which are not important, but this question can come in the examination. What are the causes of hemoptysis in Eisenmenger syndrome, which of course could be usually due to a rupture of a pulmonary arteriole or a pulmonary artery branch. It could also be due to pulmonary thromboembolism. There is a tendency to bleed in these patients. All cyanotics like collaterals, bronchitis. We used to say about winter bronchitis in mitral stenosis as a cause of hemoptysis. That could apply here also. So these are some of the causes of hemoptysis. Then, very importantly, the survival of Eisenmenger syndrome. This is a study which showed 10 years survival is around 80%. So when this particular study was done, at that point of time, the survival of an idiopathic PAH, this is around 10 years back, was only 20%. So we used to learn very easily. That is Eisenmenger, 10 years survival is 80%. Idiopathic PAH, 10 years survival is 20%. Now at 25 years, half of them, more than half of them will die from the onset of symptom. Very important. And Dr. Saha was my 1 year senior, and he had done a very good study from Chitra in 94. And he showed the cause of death. I think the most important cause of death in him was sudden cardiac death, followed by heart failure. And then hemoptysis was 15%, brain abscess, and pregnancy-related issues. And there were, of course, people looking at the predictors of death. They will ask you, this is very important in Eisenmenger, they will ask you what are the predictors of death. So according to this recent study, older age group, pre-tricuspid, that is very interesting. If you have pre-tricuspid shunt developing Eisenmenger syndrome, things are not very good. Which again tells you that pre-tricuspid shunt with a severe Eisenmenger has some sort of an idiopathic pH-like situation and lower saturation at rest and pericardial effusion. That is an interesting phenomenon. Another study by Dilla, another large number, little earlier, functional class, heart failure, arrhythmia, QRS duration also. The basic point is that you reduce 20 years from your longevity if you have a Eisenmenger syndrome. That is again another question which is asked. How many years are subtracted from your average age of survival is 20 compared to control population. These are, of course, they are all some sort of, they sound like a mathematics, but of course they are being asked in the examination. And according to Saha, my friend, sudden cardiac death was the most common cause of death. And for Chitra study, only three, on a multivariate analysis, only three things were important. One was saturation, less than 85%. RA mean pressure elevation, history of syncope. They were the three most important factors predicting death in that patient. And this is another area where we had a girl who had a hole, who developed Eisenmengerization, typical rat tailing, etc. Mild cardiomegaly, as you can see, this was a VSD Eisenmenger, and she was offered medical management, and she was specifically told not to get married, but she married against medical advice because, as I told you before, they went for some prior meeting, and she met a priest, and then they got married, and 24 weeks comes saying that she's pregnant. Very difficult nowadays because 24 weeks means you cannot do a therapeutic termination. You have to continue a pregnancy. So the point I want to ask you is that if you have a lady patient, whether it is post any lady patient with an Eisenmenger in your case discussion, invariably questions will come on the management of pregnancy, even though she is unlikely to become pregnant. That may be, but they will ask you because when lady comes with a pulmonary hypertension, so you should be very clear about this. The best thing is, of course, to prevent pregnancy, and then, of course, the antenatal care, lateral position, oral hygiene, travel, and peripartum care, when to admit, and a questionable use of anticoagulant. You should go through them. I will not go into detail because it's already 7:05. And anyway, Sudhakar and I will try to put it somewhere so that you can access this PowerPoint presentation. But the point I want to make is that you will be asked two major areas. One of the very popular chapters in Brownwall, as you know, is pregnancy and heart disease. You must be thorough with that particular chapter, and also very thorough with the management of two things: Eisenmengerization and Fontan circulation in pregnancy, because you will get a person, you can get a case of a univentricular heart with either a Glenn or a Fontan completion, and they can ask you the management of pregnancy. So this is very important. So I will quickly go through this. The only thing is that a very important thing is that the bosentan is a very useful drug in Eisenmenger syndrome, is not to be used in pregnancy because it has got a teratogenicity. Otherwise, the rest of the drugs can be given. And, this is okay. And Eisenmenger syndrome is one of the highest risk for mortality during pregnancy. Fetal outcome also is relatively poor, depends on the functional class, all those things. And there are some scoring systems also, which I think most of you would be very familiar. And pregnancy, again, drug teratogenicity, fetal echocardiography has to be done, all those things. Then this was actually a post-operative pulmonary hypertension, unfortunate. He had a large VSD and operated 3.5 years, but still he has now systemic PA pressures and is basically another variant of Eisenmenger. Is post CHD severe PH. So all he can be given is various drugs for the PH situation. Now the point is, this is just to tell you that these are some of the post-operative congenital heart disease with severe pulmonary hypertension, which could be kept in your examination. VSD post-operative case like this. AVSD post-operative with PH and left AV valve regurgitation is a usual case kept. Sending can have severe pulmonary hypertension. They can be kept. A lot of physical findings will be there. When I was a student in DM, we had one case who had a pulmonary atresia, who had a central shunt, and that was another patient who were kept. So now the question is, if a resident encounters severe PAH without much of cyanosis, we were to decide between Eisenmenger and idiopathic pulmonary hypertension. The major difference, of course, would be no history of heart failure, recurrent infection in idiopathic PAH. Cyanosis and clubbing is least or practically nil in idiopathic PAH, unless it's a very late presentation. Functional class will be worse in idiopathic PAH, and progression of symptom is very fast in idiopathic pulmonary hypertension. This was a patient who had come with severe PAH. We thought initially it was a VSD Eisenmenger, but it turned out to be an idiopathic pulmonary hypertension. The question is, again, the question will be asked, why does Eisenmenger do better than idiopathic PAH? That is, the answers are one, the subpulmonary ventricle has been exposed to high pressure from the beginning, whereas an idiopathic PAH is an acquired disease. It will happen only for the last 2 or 3 years. So that is not, subpulmonary ventricle is not exposed to this long time, this thing. Then people say that the RV remodeling, ventricular remodeling in Eisenmenger is different from that of idiopathic PAH. And of course, the right to left shunt, presence of right to left shunt is a sort of a valve, deflating valve. Now, there are some conditions. These conditions, first 2 conditions are totally different from Eisenmenger. Eisenmenger is PAH, whereas these 2 are PS. So they just like Rudyard Kipling said, East is East and West is West. They cannot coexist, but still they will somehow come up as a clinical differential diagnosis, also LTGA, and of course, complex Eisenmenger. Now, Eisenmenger versus VSD pulmonary atresia, the common feature will be cyanosis and clubbing, no heart failure, no cardiomegaly, single loud second sound. In VSD pulmonary atresia, it will be in A2, whereas in Eisenmenger, it is basically a P2 and hardly any murmur. If you can get again, but the difference will be that pulmonary atresia tetralogy, the blue color will be from infancy, very early in newborn period. Spell, I think, would be more common in tetralogy pulmonary atresia than as Eisenmenger, even though we know spell is important in VSD Eisenmenger. Then high volume pulse because of the collaterals and the continuous. If you look very carefully, you will get a grade 1 or 2 continuous murmur, which will make the diagnosis of pulmonary atresia. Then, so the same thing, which I repeated, unfortunately. So the point I want to make is that hemodynamically, Eisenmenger VSD and TOF with pulmonary atresia are far apart. Yet in an adult, sometimes it is difficult to distinguish them from one another because of these factors, because you are dealing with a mildly cyanotic person who has no cardiomegaly with a single second sound, hardly any murmur. You can be either of the 2 sometimes. And, in an adult, both survivors can present with mild cyanosis and clubbing. MAPCAS can maintain a decent saturation in tetralogy till adulthood. There will be no cardiomegaly. Outflow murmur is absent in both. S2 will be single. As I told you, S2 will be, one is P2, another is A2. So it's very difficult sometimes. You cannot totally say that this is A2 and this is P2. Most likely A2, most likely P2. That's all you can say. Another condition, very interesting condition, they can ask you one of the differential diagnosis of Eisenmenger. It is totally different, but still what can happen is the common things are mild cyanosis, no cardiomegaly, single second sound. And the only thing is that here there will be a significant outflow murmur, whereas in an Eisenmenger, outflow murmur is unlikely to be present. So the differences are the JVP is important in Eisenmenger, LPH is important in Eisenmenger, and X-ray and ECG also will be very, very helpful. Basically, it is because of that L post aorta, which is very anterior, you get a single second sound because of the pulmonary stenosis. So let me ask you this question to Sai or Karan. The least likely clinical differential diagnosis of Eisenmenger syndrome in the exam setting is which one? TOF, LTGA, Epstein, and single ventricle with L-post diode. What do you think? Very easy. Anybody?
Epstein, sir.
Epstein anomaly. It's totally different. Epstein anomaly. The rest are basically having a loud, because basically all of them will be having some cyanosis and a loud single second sound. And echo, basically look for a RVH and a D-shaped ventricle can assess. These are all very simple things which you already know. I will not go into the details of TR, PR, all those things. Saturation, the oximetry data, and survival, which already we have already covered. And this is a data. Again, they can sometimes ask you the difference in mean age of death, which has happened over the last 60 years or so. So in 1950s, in the 50s, the mean age of death was 35 years. Remember, Madhubala died at 36. But now probably the age of death has improved 45 years because of the various drugs used in this thing, especially the targeted drugs. And mean age of dying in truncus, a single ventricle, you see, look at this, 32 years due to this complex Eisenmenger. Then this we will not go into this. And the therapy, basically, non-targeted and targeted. Non-targeted, so many things, very important. These are examiners are very fond of asking these kind of questions on general principles of Eisenmenger, activity, dehydration, no Ramzan fasting, no Easter, no Ramzan fasting, vaccines for various things, iron supplementation, very careful GA, need for a supplementary oxygen, home oxygen, the controversy, iron therapy, very important, careful use of diuretic, digoxin, controversy of anticoagulant. And then the three important targeted therapy. They will ask you on PDEI, ERA, and prostanoid. And they have shown definitely symptom relief and hemodynamic improvement. We have maybe there is a survival benefit, but definitely there is a symptom relief and hemodynamic improvement. And anticoagulants are controversial. They are likely to cause bleeding, stroke, and hemoptysis. So idiopathic PH, I think we are more comfortable with an anticoagulant, whereas Eisenmenger syndrome, we are not that comfortable. Then another question which is usually asked is phlebotomy in any cyanotic heart disease, even tetralogy. They will ask you, so what is more important than the indication is the contraindication. There is no need for a routine phlebotomy. There is nothing like a prophylactic phlebotomy. Only when you have hyperviscosity and symptom, you go for a phlebotomy, because there is a efficiency, reduced exercise tolerance, impaired oxygen transport, increased risk of serious stroke, and an adult can be there because of phlebotomy. And you should know how to do, you should know how to tell the examiner to monitoring 2 IV lines, blood out, saline in, 75 ml, 55 ml out, that kind of thing. And then they will ask you, I overheard one examiner was asking that candidate whether suppose in a small child, what will be, how will you calculate the amount of blood? So the formula is weight in kilogram into 80, that is the blood volume in 1 kilogram of time. Current hematocrit, whatever it is, optimal hematocrit is around 55 divided by the current hematocrit in ml of blood. So they will give you a value. So that is that. And then lastly, these are new things which are controversial, very much controversial. So be very careful with your particular examiner, because there is a philosophy that in a borderline severe pulmonary hypertension, you treat PAH and then operate and give the targeted therapy. So treat and repair concept versus repair and treat concept, both have limited data. You should be aware of such a thing happening, which are not becoming very popular these days. Then I think we should go back and read about the Paul Wood series and Somerville. Jane Somerville is another great person in adult congenital heart disease. You should look at this data, which is very important. And of course, all self-respecting postgraduates in cardiology should know the Paul-Wood series, which had simple lesions and complex lesions. And now I think basically I did my DM in Chitra, so I am a great, what you call as, fascination for Chitra, and these two people were my friends. They saw Aravind Saha, my DM 1 year above me, and this is a good data to show. In the examination, it will be very useful because they have in detail discussed the issues, which are the common conditions like VSD, ASD, PDA. Then you have the symptomatology in these patients. It is a retrospective study, but symptomatology. Then signs in, see, for example, differential cyanosis, 10%, only half of the PDA had a differential cyanosis. The rest had either no cyanosis or some of them had a uniform cyanosis, clubbing 2/3, all those things. And you see this LPH is around 80%. So LPH is very important. Wide and fixed split in ASD, 70% in their group. And this was the X-ray findings, or what we expected, of course. ECG, almost all of them were in sinus rhythm. LAD was present in 5% because they had either an inlet VSD or a atrioventricular septal defect. These were studies. Now, one question, last question, can tetralogy develop pulmonary hypertension? Because tetralogy is totally different from this thing. I think this is a tricky area. Be very careful in the examination. You can say one answer. You can very clearly say that. Suppose you had a tetralogy who had a central shunt or a Watterson Cooley shunt or a central shunt, ascending aorta to pulmonary artery shunt, they can develop definitely this thing. And theoretically, severe polycythemia, because polycythemia PCV also contributes to the vascular resistance. But I'm not very sure about this. This is discussed as a possible cause of developing pulmonary artery pressure, higher pulmonary artery pressure in a tetralogy. So finally, Eisenmenger, as I told you in the beginning, described in 19th century, understood in 20th century, ameliorated in current century, and definitely we hope that it will be extinct in the maybe even in the end of the current century. So it will not be a Midsummer Night's Dream. It is likely to be a drama like All Is Well that ends well. And a very important thing I want to tell you, and of course you can ask questions, of course, chat, and read and reap. I think nothing can be a substitute for reading. That can be either a digital reading or the what you call the physical reading, which the old timers like me will favor. And thank you very much. I think this is one painting. On your left hand side is the painting by Van Gogh, who was my most favorite painter. And the right hand side is a painting by my most favorite person on this earth, that is my grandson. And thank God, who is the cherisher and sustainer of all the worlds. Thank you very much. And it's already 7:20. So Monica and the team can channel, or Sudhakar will channel whoever.
I'll first ask the chat box few questions are there, sir. Then we can ask them to volunteer any question.
Okay.
One question is, sir, you proceed, sir.
That is okay. Time factor.
Yes, sir. We can take five minutes.
Usually, I expected if we should finish by 7:10, but somehow okay.
So one question is, a prophylactic phlebotomy for pre-op non-cardiac surgery is indicated or not?
That is indicated. That is indicated, provided the PCV is more than 70. But it all depends on the surgeon. If the surgeon is uncomfortable with the PCV, I think you do him a favor by doing this thing. Otherwise, generally, if the surgeon says, okay, I will manage, that is better. Especially adult tetralogy mainly. Because adults with tetralogy or any severe cyanotic heart disease are the ones who are more likely to develop a CVA because of phlebotomy. Phlebotomy causing a CVA in a child is relatively less common.
Right. So basically, sir, all this phlebotomy, unless we have an iron deficiency, even with a large hemoglobin, should have an iron deficiency, we should not do any phlebotomy. Only if it is normocytic, we should do a phlebotomy.
And symptoms also. I think we should give a lot of respect to symptoms. They don't have much symptom,
right.
Let them be.
Right, sir. And sir, can large MAPCAs develop PAH in TOF? Somebody asked.
Yeah, MAPCA can develop. Yeah, that is true. MAPCA, because you have a dual supply in a pulmonary atresia with VSD. MAPCA are basically coming from the central aorta, and there may be segments. That is the point. There may be segments of the lung which will have elevated PA pressures. So there is some sort of a segmental this thing. So theoretically, yes.
Right, sir. So, and somebody asked, what is the cutoff hemoglobin level to label anemia in cyanotic congenital heart disease or Eisenmenger? So is
that is so in a way I will rephrase it in such a way. For example, in a cyanotic heart disease who is either waiting for surgery or is on medical management, the optimum hematocrit will be around 55%, because if you go back and you will find in many textbooks, you will find a graph between PCV in the x-axis and the viscosity in the y-axis. And you will find there is an increase, but at a particular point between 55 and 58 PCV, there's a sudden jump. The graph goes vertically. The viscosity becomes disproportionate. So the aim is to maintain somewhere between 55 to 58. And anemia, I think, should be diagnosed by a peripheral smear and other biochemical investigations rather than looking at hemoglobin. Anemia has to be, I think the simplest way in a simple hospital would be a peripheral smear. But in a bigger hospital, we can always do ferritins or those.
Right, sir.
All the indices. And another thing, another point I want to tell you that when you have a cyanotic heart disease discussion, not only Eisenmenger tetralogy, people are very fond of asking the red cell indices, MCH, MCHC, all those things. So you should know that before coming to the exam hall.
So somebody asked, if in a patient of 8 to 10 years or 15 to 18 years, based only on history, should we keep Eisenmenger as a differential diagnosis?
That's a very, very, very interesting question. See, I'll put it in a different way. For example, if a child has survived up to 10 years with cyanosis, naturally the number one, history-wise, the number one diagnosis has to be a tetralogy or a tetralogy-like physiology, out of which I think we will have tetralogy, DORV, LTGA, VSD, PS, single ventricle PS. These are the most likely, whereas DTGA, VSD, PS is probably likely to die much earlier. So that is one area. Another cyanotic, we also know that LTGA, VSD, PS with a favorable streaming. Epstein is definitely comes. So the question is whether to put Eisenmenger into the differential diagnosis based on the history of the age of this 10 years. See, we all of us, I think, Sudhakar, we have all seen children below 10 years with severe pulmonary hypertension amounting to Eisenmenger. We had one or two patients with a large VSD with mitral valve abnormality, mitral valve stenosis, etc., who developed Eisenmengerization much earlier. It is possible, but as a differential diagnosis, I think they should come little low in the list. But you can always argue to the examiner, sir, I am also thinking of a complex type of Eisenmenger, which has survived up to this particular age. Because one way of, truncus, TAPVC, single ventricle PH, they all actually, even if they survive because they develop PVOD. Otherwise, they would have died earlier. So that is also possible, but should come lower in the list.
Sir, that many people, they keep on like, how common is this Katz-Wechtel in ECG in a VSD Eisenmenger? Means will they still persist that pattern?
No. It will not persist. Actually, only one, I think based on Paul Wood's study, the only Eisenmenger which has some LV, reasonably good LV activity with a small Q and all, is a PD Eisenmenger. VSD Eisenmenger definitely will have RVH only, not Katzwackel phenomenon. Definitely.
Right. So last 2 minutes, I'll ask the panelists if they have any doubts or any questions before we. Any of the
Sir,
panelists?
just one small question, sir.
Yes.
If an ASD Eisenmenger comes to us and she has a patient has a suprasystemic pressure, so JVP will have A wave prominent.
Yes.
But the patient will invariably have TR. TR murmur is also there.
Yes.
Then we may get confused if it is A or B wave. But what is common? Whether it should be A or it should be B.
Oh, it should be. But generally, if you find such kind of an adult with an ASD Eisenmenger with significant TR murmur, I think generally we expect the V wave, no? We expect a V wave rather than the A wave.
Even if the pressures are suprasystemic.
Even if the pressures, pulmonary artery pressures are suprasystemic. See, well, the point is that you think of other conditions of severe PAH, where you have suprasystemic PA pressure. Think of a pulmonary stenosis, severe pulmonary stenosis with reversal at the atrial side with an RV dysfunction. What can happen? What happens is that RV pressure is suprasystemic, and you will have a TR being more prominent than the outflow murmur. So that can coexist.
Okay. Yes, sir. Thanks, sir. Thank you.
Sir, you showed one ECG of a Eisenmenger with a PDA and ductal calcification.
X-ray.
X-ray, sir, sorry. So I remember in my exam they had kept one such X-ray and asked the other differentials of a ductal calcification. Okay. So in your experience, which all places do we see such calcification in the area of the ductus, sir?
Right. One is one classical condition other than Eisenmenger situation is a ductal aneurysm. You can have a ductal aneurysm which can calcify in the adult age. So that is another very important complication which can have calcium. So I am aware only of these two conditions. One is a PD Eisenmenger with calcification, and second is a ductal aneurysm.
So sir, can this idiopathic PH?
When see, usually in the previous era, a large PDA was they were divided and sutured, whereas the moderate PDAs were ligated, triple ligation. So some of that triple ligated PDA, sometimes there can be an aneurysm formation. So they if they persist into adulthood, can have some sort of a calcium also. So that is a one differential diagnosis. I am not aware of further difference.
And so similarly, you have shown one more case of an aneurysmal PA.
Yeah.
Like what other common differential diagnosis will that have? Aneurysmal PA like that, sir?
Aneurysmal PA, the one kind of that is not in an adult. There is a the condition tetralogy with an absent pulmonary valve syndrome, where you have both RPA and LPA, especially the RPA are aneurysmal, LP are aneurysmal, which is basically a tetralogy with a severe PR. So that can have an aneurysmal pulmonary artery. Then Eisenmenger, with different kind of Eisenmenger. Idiopathic PH, somehow we don't see that kind of aneurysmal pulmonary artery.
Right, sir. I think that answers. Somebody asked for vasodilatory test. What all modalities like oxygen, NO, and others used commonly at different centers in India?
Yeah, I think Sai, I think Chitra, it is still oxygen, right?
Yes, sir. Most commonly oxygen. Occasionally we use nitric oxide. But most commonly is oxygen.
Amrita, basically, it always used to be nitric oxide. So these are the two texts which are generally used.
But I have one question. Do we still do like in Eisenmenger and all vasoreactivity? Should we do in all patients?
Oh, that one. Your idiopathic pH.
Right, in pH, including pH, sir.
Okay. So idiopathic pH, I think we definitely suspect you're ruling out an Eisenmenger, and if you're making a diagnosis of an idiopathic pH, definitely you're justified in doing a vasoreactivity testing, because in an adult only 10% are responsive to this, and in children are better. There are 20% of them respond to this vasodilator. So naturally, one of the important steps would be to do a vasoreactivity test. Whereas in Eisenmenger, I'm not very sure that Eisenmenger in proven Eisenmenger vasoreactivity test may be useful. Rather than that, what we generally do before that step is to decide on operability. Once you decide convincingly that you are not going to operate, I'm not sure whether vasoreactivity testing will be of great help.
Sir, so if somebody has a, like we showed in one case, a VSD Eisenmenger, baseline SUNT of 1:1.4, and then a borderline PVR. So is just seeing a baseline, can we just tell that it's not reversible? A baseline of...
You cannot say for sure, but the point I was making is that this borderline values, naturally, 10 years back, we were very much enthusiastic about the oxygen study. And if the oxygen study improved, some changes were there, we were very happy to oblige, saying that, okay, this child has to be operated. Now we are being little more circumspect. That we took, for example, there is one study, ASD, we thought it was initially inoperable, but the shunt became almost 3:1. You remember this one lady, Amrita patient. So that was a good decision. But there may be another patient where there may be an increase in all the parameters, but they may end up with problems. Especially ASD Eisenmenger, we have to be doubly careful because the standard saying is that you don't convert an ASD Eisenmenger into a sort of idiopathic pulmonary hypertension with its very, very, very fatal natural history. So you see, I think Sudhakar, when we were doing DM in the ancient days in the 90s, we used to have different cutoff line for wood units. For example, we were very liberal with PDA. Even with 10 wood units, we would go and close the PDA. 8 was for VSD and 6 was for ASD. But that has changed. Later on, in the 20s, 200, this century, we said for everything, it was 8 wood units, as quoted in Kirkley. Now we have brought down that also to 6. So there has been, that is what I have been trying to do. There has been a tendency to be very, very strict with the operability criteria, because I think even from India, from Chennai, I think Dr. Subramaniam, you may be knowing, very senior person, my teacher, he has some studies showing that this borderline PH situation operated, they don't have much reduction in the PA pressure post-surgical.
Right. I think there are no other questions, sir. Should we conclude, sir? It's already, I think.
It's already 7:30.
It was a very long and very informative session, sir. Almost all the questions related clinical related to exams were covered with clinical scenarios. And yes, sir.
The way you speak, I almost believe you. Anyway, okay.
I know now you are correct, sir, that it should not be an exam oriented, but somehow as the exam comes near, people go for exam oriented.
Exactly, because you have to survive. Survival. The examination is always a law, but generally, so we must be thankful. DM candidates should be thankful that compared to MD, either pediatrics or general medicine, things are much better because our internals know us. We will usually survive, but we should survive with sort of some respect, self-respect. That's all. That is why we are training you like this.
Right.
So, in Chitra, I remember my last sentence, when I was doing, there was a neurosurgery chief, Dr. Raut from Orissa, very tough man. I think he was, he moved over to Chennai. He's one of the leading aneurysm surgeon in the world. So he had 4 MCH PGs. By 3 months, 1 MCH PG will leave the hospital because of his the terror unleashed by Dr. Raut. Invariably. So only 3 people will be left at the end of 3 to 6 months. And by the time the 4th person will not come. Then what happens is that at the exam, just before exam, he will call all the 3 or 4 and tell that you go and study, you will pass. You will pass. But don't make me beg for your pass. So it gives a lot of relief to the candidate, right? Because anyway, I'm going to pass, so they will be very comfortable. Anyway, so the second half of Dr. Raut's behavior is excellent for a postgraduate, I believe. Anyway.
So I think we'll conclude this session, sir. I'm very thankful to you, sir, to give us time for this one of the important sessions like EISENMENGER, which definitely is one of the either a long question or a short question case for the exam going both in theory and in the practicals.
Correct.
Right, sir. So Rahul, you have anything to?
Yes, sir. We are on the verge of concluding this exciting program, and at the outset, I would like to thank Dr. Zulfikar sir for keeping the things very simple and addressing most of the queries posted by our colleagues. And I thank Dr. Sudhakar Rao for this particular initiative under the PG Bonanza webinar series. We at Torrent are always available with this virtual platform and assist and support you in this academic endeavors. And we look forward for your support for Torrent also in the times to come. Thank you and take care, sir.
Thank you, Rahul, and the unknown soldier.
So I'm known to Dr. Sudhakar Rao from quite well now.
Just joking.
Thank you. But sir, Dr. Zulfikar sir, we had you for the first time in this platform, and we had a very good learning session. Thank you.
Thank you. Thank you very much.
Thank you, sir. Thank you, sir.